Hello, I'm Dr. Caitlin Chambers. I'm a sports medicine orthopedic surgeon and an assistant professor of orthopedic surgery at the University of Minnesota. Today, I'll be taking you through the hip exam in preparation for the Bellringers workshop. You should first inspect both hips from the front and back. Observe gait pattern as the patient walks away from you and back towards you in a hallway. Next, you should proceed with palpation of bony landmarks. Looking from the anterior aspect of the patient's hip, you can identify the ASIS, or anterior superior iliac spine, denoted by the arrow in red, the AIIS, or anterior inferior iliac spine, denoted by the arrow in yellow, and the hip joint, which lies medially to both of these structures and is seen marked by the blue arrow. With the patient in the lateral decubitus position, you can palpate the greater trochanter, which is the attachment point of the hip abductors, denoted by the arrow in red, and you can also palpate the IT band, which extends from the hip all the way distally past the level of the knee, as seen with the arrow in blue here. Now, with the patient prone, you can palpate the sacroiliac joint, which is seen at the level of this arrow in red. You can now begin your range of motion assessment with the patient laying supine. Flexion is assessed by flexing the knee to 90, then pulling the knee upwards towards the chest, stopping when the patient's back begins to flatten. Normal flexion range of motion is 120 degrees. Internal and external rotation are assessed with the patient's hip and knee flexed to 90 degrees. In external rotation, the foot is moved toward the midline, thus turning the proximal femur outwards. External rotation of the hip averages 60 degrees. In internal rotation, the foot is moved away from midline, thus turning the femur inwards. This is 30 degrees on average. Abduction is tested as the amount that the leg can move away from midline, averaging 45 degrees. Adduction is measured as the amount that the leg can move towards midline, averaging 30 degrees, although this can be limited by body habitus. Now, with the patient prone, hyperextension can be assessed. With a bent knee, lift the leg off of the table. Stop when the patient's pelvis begins to shift, as felt with your hand on their low back. Average hyperextension of the hip is 15 degrees. Strength testing is next evaluated and graded on a scale from 0 to 5. Hip flexion strength can be assessed with the patient seated or supine. Hip abduction strength testing is performed by placing the examiner's hands on the lateral thigh as the patient attempts to move their legs away from midline. Adduction strength is assessed by placing the examiner's hands on the medial leg as the patient attempts to move their feet inwards. Extension is tested prone, with the patient lifting their entire leg from the table against the examiner's downward resistance. Sensory examination when assessing a hip joint includes evaluation for any numbness along the lateral aspect of the thigh, which is the distribution of the lateral femoral cutaneous nerve. This area can have numbness or pain in the setting of meralgia paresthetica, which is a condition caused by compression of the lateral femoral cutaneous nerve as it crosses over the prominent iliac crest. This can be caused by compression from tight pants or waist belts. Another pertinent sensory distribution and evaluation of the hip is that of the obturator nerve, which provides sensation to the medial thigh and groin all the way down to the knee. This is the reason that some patients with hip pathology can present complaining of thigh or knee pain. There are a few special tests important in the evaluation of a patient's hip. The Trendelenburg sign is seen in cases of hip abductor weakness or injury. The patient is asked to perform a single leg stance on the affected limb. With the unaffected foot raised off of the ground, the unaffected hemipelvis drops lower in a positive Trendelenburg sign. This also occurs during stance phase of gait on the affected limb, and patients compensate for this by swaying their trunk laterally over the affected limb to even out the pelvis. This is referred to as a Trendelenburg gait. Ober's test is performed with the patient laying laterally with the affected side facing up. The knee is bent to 90, and then the hip is passively extended backwards, then adducted, dropping down towards the table. A positive test is seen with the inability to passively adduct the leg and is indicative of IT band tightness. Leg length discrepancy should be calculated by measuring the length from the anterior superior iliac spine to the medial malleolus and comparing side to side. A log roll test is performed by gently rolling the patient's leg back and forth. Severe pain with the log roll test can be seen in the setting of a hip fracture or septic hip joint. Other findings in the septic hip joint include the inability to bear weight, elevated inflammatory markers such as white blood cell count, erythrocyte sedimentation rate, and C-reactive protein, and patients are often encountered resting the hip joint in a flexed, abducted, and externally rotated position, as this is the position that maximizes hip capsular volume and is most comfortable for these patients. SCFE, or slipped capital femoral epiphysis, is a condition seen most often in overweight adolescents. This involves a disruption of the proximal femoral physis, or growth plate, which results in a slippage of the femoral metaphysis relative to the epiphysis, resembling an ice cream scoop falling off of its cone. These patients lack passive internal rotation of the hip due to impingement of the displaced metaphysis against the acetabulum as the hip is flexed. This results in obligate external rotation, meaning that the hip is seen to naturally externally rotate as it is brought into a flexed position. Developmental dysplasia of the hip is a condition in which the acetabulum, or socket side of the hip joint, is abnormally shallow. This results in posterior instability of the hip joint, ranging from temporary subluxation of the hip out of its socket to fixed dislocation. 2 physical exam tests are routinely performed on all newborns to screen for this condition. The Ortolani test assesses for a dislocated hip joint. The infant's leg is brought from a flexed position into a position of flexion and abduction with an anteriorly directed force on their proximal thigh in an attempt to reduce the posteriorly dislocated hip joint anteriorly back into its socket. The Barlow test assesses for a hip which is not dislocated but can be subluxated out of the joint posteriorly. For the Barlow test, the infant's hip is flexed to 90 degrees and a posterior axial load force is applied, followed by adduction of the hip. A clunk is felt in a positive Barlow test as the hip subluxates posteriorly out of its socket. This concludes the overview of the hip exam. Thank you.